Good evening, delegates and faculties members and attendees. Thank you for joining Shield Connect. And today, the webinar is about knowledge, attitude, and practice series sponsored by AMOX Medical Disorder Committee with Urogynecology Committee FOXY. And it has been sponsored by AMOX Medical Disorder Committee Offices Bearers. So, Saiti, please flash the CV. So, our conveyor for the day is Dr. Suman Sinha ma'am and Dr. B. Kalpana ma'am. So, Dr. Suman Sinha ma'am is the president of Ranchi Obstetric and Gynecology Society. Ma'am is senior consultant at AH IVF and Infertility Center Ranchi and director of Advanced Care and Maternity Center. Ma'am is also ex-chief of medical service and HOD of obstetric gynecology at CCL Hospital Ranchi, a subsidiary of Coal India. Ma'am is also president of Ranchi Obstetric Gynecology Society since 2021 to 2023 and East Zone Coordinator Medical Disorder in Pregnancy Committee FOXY in 2019 to 2022. And ma'am has also been published in many uh, journals and organizing chairperson of ISOBAP midterm conference, trained in laparoscopic surgery from AIMS New Delhi and Vadia Maternity Hospital Mumbai. And ma'am has been also appreciated by Dr. Durusha Appreciation Award for Growing Up Program, 2008 Kumar's Award for Best Paper in Obstetric and Gynecology in Coal India National Conference, and conferred FICOG and FIOG. Now, I also introduce our second convener of the day, Dr. B. Kalpana ma'am. Uh, Doctor is a gynecologist and infertility consultant at Guru Hospital. Ma'am is national coordinator and infertility committee of FOXY, and ma'am is chairperson of infertility committee of TNFOG, secretary of MOGS, and founder secretary of Madurai chapter of Tapisar. Ma'am is EC member of Infertility Committee FOXY since 2017 to 2020, and ma'am is a course director for post-doctoral fellowship in endogynecology, member of institutional ethics and principal investigator in clinical trials. And ma'am has also published 15 papers in national and international journals and invited as a guest lecturer in many national international conferences. Ma'am has been awarded with the Best Doctor Award by Dr. MGR Medical University, Golden Excellence International Award by European Continental University, Medical Excellence Award of 2018 from Governor of Tamil Nadu, and Best Medical Service Award from Madurai District Collector. So now I hand over this session to Dr. Suman Sinha ma'am. Ma'am, we welcome you on our platform for this webinar. Thank you, ma'am.
Thank you, Nishanji. I wish you all a very warm and great evening. And now I take the pleasure and honor to welcome all the dignitaries, our esteemed guests, and dear delegates in the Knowledge, Attitude, and Practice series in association with AMOX Medical Disorder Committee with Urogyne Committee, FOXY. The societies joining today are Ranchi, Jorhat, Guwahati, Dibrugarh, Parbhani, Latur, and Nanded. I welcome our honorable respected chief guest, past President FOXY, Dr. P.K. Shah sir. I welcome AMOX President, Dr. Rajendra Singh Pardesi. I welcome AMOX Secretary, Dr. Sujata Dalbi Madam. I welcome our revered guests of honor, Dr. Krishnendu Gupta sir and Dr. Bhaskar Pal. I welcome our very proficient speakers, Dr. J.B. Sarma sir, Dr. Mangesh Narwadkar sir, Dr. Gurlidhar Pai sir, Dr. Saswati Chaudhary madam, and Dr. Sneha Bhagar madam. I welcome all our esteemed chairpersons, Dr. Amal Fukan, Dr. Kiran Trivedi, Dr. Prashad Magar, Dr. Varsa Kadam, Dr. Jasmina Sharma, Dr. Deepti Goswami, Dr. Swati Gaur, Dr. Kishore Atnurkar, Dr. Nilakshi Fukan, Dr. Pranay Fukan, and Dr. Rakhi Sarda. I welcome our program director, again Dr. Sneha Bhagar, for bringing West and East together for exchange of knowledge. I welcome my co-convener, Dr. Kalpana, and Secretary Ranchi OG Society, Dr. Kiran Trivedi, for their valuable support. I welcome academic partner from Shield, Mr. Nishant and Sahiti Priya, whom I have been troubling them since morning, and for always being so helpful and supportive to us. I look forward for a very brilliant academic session. Now we are going to have the lamp lighting.
Kurutvam kalyanam arogyam dhanasampadam shubham kurutvam kalyanam arogyam dhanasampadam shatrubuddhi vinashaya deepajyotirnamostute deepajyotirnamostute shubham kurutvam kalyanam आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं.
Now I take the honor and opportunity to introduce and invite our program director, Dr. Sita Nair Madam, for our welcome address. Can I have Madam CV? Yeah, thank you. Madam is the very dynamic past chairperson of Breast Committee FOGSI. She is presently governing council member ICOG for the year 2021 to 2022. She is presently chairperson Medical Disorder Committee of AMOX for 22 to 24. She is founder president of Vidarbha ISOPAR from 2017 to 2019. She has been president of YOX since 2007 to 8.
Okay, thank you, Suman.
Just a minute, madam. She is recipient of many awards and accolades. Her research work has been published in more than 27 national journals. She is invited speaker in more than 200 state, national, and international conferences and has more than 30 years of experience in the field of obstetrics and gynae. Welcome, madam. If you can welcome for the welcome address, otherwise I will read your message. What do you say? Can you?
Thank you so much. A very good evening. I'll just try to speak only few words and without taking much
it will do.
Yeah. Respected Dr. P.K. Shah, sir, my mentor. Respected Dr. Krishnendu Gupta, my dear friend, Dr. Bhaskar, Dr. Rajendra Singh Pardesi, President AMOX, and Madam Sujata Dabri, Secretary AMOX. Our speakers, Dr. J.B. Sharma and Dr. Mangesh Narwarkar, who is the past chairperson for Urogynec Committee, and of course, all the respected Dr. Muralidhar Pai and all the esteemed chairpersons, all the president and secretaries of all the societies, you have already enumerated them, and all the delegates. I welcome all of you here. This is almost the 25th program of AMOX Medical Disorders Committee. And for every program, we are intermingling the various zones together. And along with Medical Disorders Committee, we are trying to liaison with various other subjects which we can club in together. Like we are also planning to go for fetal medicine and all other allied subjects. So I welcome all of you. And of course, I seek all your blessings for my endeavors. With your blessings, I have pressed my two positions till now, the chairperson of the press committee, and I'm still working as GCM ICOG. And with all of your blessings and best wishes, I much wish to go ahead for what Vice President FOGSI from West. Thank you so much. Thank you.
Thank you, madam. Now I would like to welcome and invite Dr. Rajendra Singh Pardesi, sir. Yeah.
It's okay. It's okay. Suman, it's okay.
One line, sir. One line, sir.
It's okay.
Sir is a well-known figure in FOGSI, and he is presently president of AMOX Society.
I'll just say a few words about him, Suman. Sir is, of course, the AMOX president and past vice president of FOGSI, and he was the chairperson for Food and Drugs Committee. And sir has so many publications and awards to his credit. And above all, he's a very humble and gentle human being, very helpful.
Thank you.
So I seek your blessings.
Thank you so much. Just I wish to add in my biodata. I'm disciple of Dr. P.K. Shah, sir. She was my mentor when I was in Sion. So I think this is the biodata sufficient for me. So respected chief guest, Dr. P.K. Shah, sir, I'm feeling proud and honored to be chief guest of Dr. P.K. Shah, sir. I'm attending this webinar. Guest of honor, Dr. Krishnendu Gupta, Dr. Bhaskar Pal, and Dr. J.B. Sharma, and our AMOG's office bearers, Dr. Sujata Dalvi, Dr. Kiran Kurtakote, and Dr. Ame Purandare, and Dr. Sneha Boyar, and Dr. With Sneha Boyar, Dr. J.B. Sharma. I wish to congratulate Dr. Sneha Boyar and J.B. Sharma with the conveners, Dr. Suman Sinha and Kalpana, Dr. Kalpana Balamurugam, for organizing this wonderful webinar on practical tips on Urogyne, PIH, and NDVH, with the galaxy of speakers like Dr. J.B. Sharma, Dr. Mangesh Narwadkar, Dr. Sneha Boyar, Dr. Saswati, Dr. Muralidhar Pai, and all chairpersons. I think this will be going to a great event. I wish every success to Dr. Sneha Boyar, our ever active chairperson, ever smiling chairperson of AMOGS, for her future endeavor in FOXI, and also wishing every success to Dr. Suman Sinha and Dr. Kalpana Balamurugam for their future endeavors in FOXI. Wishing every success to this webinar. Thank you so much for inviting me. Thank you.
Thank you, sir.
Thank you, sir, for your blessings. And now I'd like to welcome and invite Dr. Sujata Dalvi, madam. Madam is a consultant obstetrician and gynecologist of Mumbai Society.
And that's fine.
She is presently secretary AMOGS, and she is joint associate editor of Jogi. It's a matter of pride, madam. And she is also clinical secretary, Mumbai Obstetric and Gynecology. Welcome, madam, and we'd like to seek your blessings.
Yeah, thank you, Suman, for a kind introduction. It's my proud privilege to be connected with today's program on knowledge, attitude, and practice series by AMOGS Medical Disorder Committee and Urogyne Committee of FOXI. AMOGS Medical Disorder Committee Chairperson Dr. Sneha Boyar and Urogyne Committee of FOXI Dr. J.B. Sharma. I would also like to acknowledge the efforts made by the convener Dr. Suman Sinha and Dr. B. Kalpana. I would like to acknowledge the presence of Chief Guest Dr. P.K. Shah and Guest of Honor Dr. Krishnendu Gupta and Dr. Bhaskar Pal. And today's topics have variety of topics, right from stress urinary incontinence to overactive bladder to NDVH, and even on pregnancy-induced hypertension. And the speakers are also so well proficient in their subject that those who have logged in will definitely learn something from today's webinar. And I wish all the best to all the participants who have participated in today's program, and special wishes to Dr. Sneha Boyar, Dr. Suman Sinha, and Dr. B. Kalpana for their future endeavor in FOXI. All the best.
Thank you, madam, for your lucid words of blessings. And now I take the privilege and honor to welcome our chief guest, Dr. P.K. Shah, sir, who is a name in FOXI. He's been past president of FOXI, and he is the master of ultrasonography. I don't know how many of us were trained under his guidance. So welcome, sir. Sir is presently professor and unit head of Department of Obstetrics and Gynecology at DS Medical College and KM Hospital at Parel, Mumbai. He is past dean of Indian Medical Ultrasound.
Suman, enough.
Sir, it's
That is enough.
Such a vibrant CV, sir.
Yeah,
so let me read 1 or 2 points more.
That is enough.
I think enough, Suman. Let sir speak. We
Okay,
are eager to
sir,
know.
seek your blessings.
Thank you, Suman. First of all, good evening to everyone. And it is so nice to see that I'm invited in Silver Jubilee program of CAPS series by Medical Disorder Committee headed by Dr. Sneha Boyar. Also by the Urogyne Committee of AMOGS. So nice to see President Rajendra Singh Pardesi, Dr. Sujata Dalvi, and the rest of the office bearers of AMOGS. Thank you very much for having me with you all. Sneha, special thank to you and all the very best from the inner core of my heart for all the contests that you want to have in future. And thank you for having me. Suman, same thing to you, and Dr. B. Kalpana. All the best to both of you. It is so nice to see and share the platform with my colleagues, Dr. Krishnendu Gupta and Dr. Bhaskar Pal will be joining us as guests of honor. And we have superb, renowned speakers, starting with Dr. J.B. Sharma. I'm sure all of us know him so well. Very good teacher. Then Dr. Mangesh Narwadkar, Dr. Sneha herself, Dr. Saraswati Sanyal Chaudhary from East, and Dr. Muralidhar Pai. All very good speakers. So fantastic selection of speakers and topics. And as Dr. Sujata said, all those who have joined us will definitely gain something from today's webinar. And I wish all the very best to all the committee chairpersons of AMOGS and to AMOGS office bearers. Thank you for having me. All the best. Thank you.
Thank you, sir.
Thank you, sir.
Take the honor to welcome and introduce Dr. Krishnendu Gupta, sir, our guest of honor. Can I have his CV? Sir has a very vibrant CV and a very well-known personality in Foxy. He is known for his academic excellence and also for his music. He is a very good singer. So regarding his academic career, sir is doctor and unit head of Department of Gynecology.
Suman, I think we can't
Suman,
hear.
Suman.
Yeah,
Yes,
please.
sir. So
Sumanji,
I
I think let's leave it at that. I'll just say a few words because we are really
we are
running
getting
short
late.
of time.
Acha,
Thanks.
sir.
Yeah.
Okay, sir. See.
So respected P.K. Shah sir, whom I know as since my postgraduate days, I had the good fortune, thanks to our teacher, Professor Pratap. He used to call all the stalwarts from all over India, and we had a fantastic training thanks to people, stalwarts like Professor P.K. Shah, Narendra used to come, Jaideep, all of them, and we were very lucky. So thank you very much, Dr. Sneha, for this opportunity, along with Dr. Rajendra Singh Pardesi. I think both Dr. Rajendra as well as Sneha have really given a nice preamble as to the galaxy of speakers who are going to speak. I see my dear friend JB here, Mangesh, and of course, Dr. Shashwati. I don't see her online yet, but Sneha will be speaking. Yes. And of course, my dear friend Murli, who, with whom Professor P.K. Shah knows we were postgraduates together in Manipal, and now he happens to be the dean of the Sikkim Manipal Institute of Medical Sciences. It's a great opportunity. I've had the opportunity of participating in the AMOGS programs even last year, and even during COVID times. I remember many a time I've had the opportunity to speak, and Pratik did a great job when he was looking after it as well. And Sneha has now finished more than 25 programs, which just shows the Herculean task which she has taken over. And thank you again very much for the opportunity. And since I was telling you that all of us are now rushing to the Bengal Society office for a long night ahead, so I would thank all of you again for this great opportunity, and great to be here. Thank you so much, Sumanji. Thank you for the numerous phone calls that you made.
Thank you so much for doing this.
Thank you.
So now I invite Dr. Kalpana to introduce and welcome our guest of honor, Dr. Bhaskar Pal.
With the blessings of our chief guest P.K. Shah sir and Krishnendra sir, we are now requesting Dr. Bhaskar Pal sir to give his blessings. Sir is senior consultant.
Thank you, Dr. Kalpana. Dr. Kalpana, that's enough. It's in his zone. I'm sure it is not required to introduce me. Thank you very much, Dr. Kalpana, for the introduction. Thank you, Dr. Rajendra Singh Pardesi, for inviting me to the AMOGS webinar, as well as Dr. Sujata Dalvi. We have a wonderful program, and we have 5 stalwarts speaking here. And it's always a pleasure to be in Dr. Suman Sinha's program. Suman is a very old friend, a dear friend, and a very, very meticulous person. For those of you who've been to the Yuva Foxy at Ranchi would have seen that. And I hope Sneha's voice does justice. But all the best to you, Sneha, for your endeavor in for becoming the vice president of Foxy, and I'm sure you will succeed. And whatever Sneha does, she does with a lot of sincerity, whether be it the breast committee of FOXIAD, whether it be the medical disorders committee of AMOGS. So I wish the program all the best. Thank you very much.
Thank you, sir. Thank you so much for your blessings. Thank you, Rajendra Singh Pardesi, sir, and Dr. Sujata Dalvi, ma'am, for blessing us. You are always with us. Your blessing is really important and helping us to move further forward, sir.
Now we move on to the academic session.
Yeah.
So please introduce our chairpersons.
It's my pleasure to invite the chairperson for the first session, Dr. Amal Kumar, who is the president of Jharkhand OG Society, senior consultant and past general secretary, endoscopic surgeon, director of Sanjeevani Hospital, Assam. Welcome, sir. Our next chairperson is Dr. Kiran Trivedi, who is an associate professor, Department of OG, Rajendra Institute of Medical Science, Ranchi, past joint secretary, Ranchi OG Society, and treasurer, Ranchi OG Society, life member of various organizations, presented papers in national, international journals and publications in national and international journals. Welcome, sir. Over to you, chairpersons. You can introduce the speaker, who is JB Sharma, who is going to share his extensive knowledge.
A very good evening, ma'am. So it's my prime privilege to introduce our esteemed speaker, Dr. JB Sharma, sir. We are always mesmerized with his lot of books and literature, which is written by him. So I'm going to see the CV of sir, please.
Yeah, it is displayed. Kiran, can you see it?
So
It's
it is
displayed.
It is on display.
Dr. GB Sharma, sir, needs no introduction. He is currently working as professor at AIIMS, New Delhi, ex-professor of Maulana Azad Medical College, New Delhi. And he also worked for a few years in UK and awarded BC Roy Award by Honorable President of India in 2015 for research in field of OBGY. And 350 publications in indexed and non-indexed journals are in his credit, with 200 in peer-reviewed indexed journals and international and national both. Author of textbook of obstetrics and gynecology. Both we are seeing the students are studying in the medical colleges. Midwifery and gynecological nursing as well. Edited 2 books and written 5 chapters in John Studd's Progress in Obstetrics and Gynecology and published for UK. He is editor-in-chief of Obstetric and Gynecology Today and is presently the chief editor of the Indian Journal of Pediatrics, Obs and Gynae. He is also a member of editorial board and won Indian Medical Council Award. So, sir, the stage is yours.
Yeah. Thank you. Thank you, Dr. Kiran, for your nice introduction. And I thank Dr. Suman Sinha for her great introduction, and all the stalwarts and chairperson, respected chairperson, Dr. Shah, Dr. Bhaskar Pal, Dr. Stogi, and everyone. Thank you very much. So my topic today is recent advances in stationary incontinence. Can you hear me?
Yeah, we can hear you, sir.
Yeah, can it be made slideshow? And then, yeah, thank you very much for my slide.
Where it is.
Yeah. Okay.
That is nice. A new thing for me now.
So we'll be discussing about recent advances in stationary incontinence. That's what Dr. Suman wanted. Next, please. Yeah, if someone can. Yeah. Next, please, ma'am. Thank you.
Yes.
Okay, so all of us know that bladder has a very important function of storage of urine and excretion of urine, and we know that bladder neck is there and the proximal urethra is there, which is intra-abdominal organ, and that keeps us basically continent. Next, please. And yeah, okay. So these are the sports of the urethra. We have extending sport in the form of levator ani muscle, endopelvic fascia, and arcus tendinous fascia pelvis, and then intending sports are epithelial cooperation of folds of urethra, tone of urethra, and urethral elasticity. This intrinsic support actually depends upon the estrogenization. Yeah, and this hypermobility also depends upon extrinsic sprint, and all this is important because when there is extreme hypermobility, that can make the patient incontinent. And similarly, in menopausal age group, this intrinsic supports are become weak because of estrogen lack, so patient become incontinent. Next, please. Yeah, so little bit about the innervation of the bladder. We know that sympathetic nervous system, is important to inhibit the bladder function. So during, like now when we are taking lecture, at that time sympathetic is dominant, and during passing of urine, the parasympathetic S2 to 4 is important, and somatic pudendal nerve, we can artificially use it during the time of micturition, and it is under pontine micturition center control. Next, please. Yeah, so we know that what is urinary incontinence, and basically, though International Continence Society says any complaint of involuntary leakage of urine is incontinence, but according to American College of Gynae, a condition of involuntary loss of urine on effort, physical exertion, sneezing, coughing, that is bothersome to the patient and frequently affects quality of life. This is important that it affects quality of life. Next, please. Yeah, so this is the grading of incontinence basically. I mean, just like and we have NYHA classification of heart disease, so I'll just simply make it grade 1, that is mild, grade 2 moderate, grade 3 severe, and grade 4 very severe, even incontinence even at rest. Next, please. So that is roughly. So this is important. And what is the basically, we know that epidemiology is low in young women, but as the age advances, especially around menopause, it peaks. And the prevalence of stress and mixed incontinence is higher than urge incontinence. And overall, up to 45% patient may have some type of incontinence in 30 to 90 years of age group. In adult women, about 15%. So we, and among women with SUI, 77% may have bothersome symptoms. So it may look more actually to us, but because in India, actually, many patients don't complain to us. They don't come. So unless you ask direct question, they are suffering in silence. The incidence is much higher. Next, please. Yeah. Yeah. So as age advances, you can see all types of incontinence, including mixed incontinence, urge incontinence test, they increase. So in the menopausal age group and elderly age group, the incidence of incontinence is more. Next, please. Yeah. Okay. So we found, I mean, we did a study in India and we found 8 to 9% in daily clinics when we asked the direct question from the patient. But when we did another study during pregnancy, so we found that SUI was seen in 19% cases in second trimester and 21% in third trimester of pregnancy. This came as a surprise because when we asked direct question from the patient, then only they gave this information. And like we didn't do anything for that other than exercising, but this is just too important to tell you that how common it is. Next, please. Yeah, so these are the various risk factors. Pregnancy, vaginal delivery are significant risk factor, and then caffeine intake, certain medication. Constipation is becoming a very important cause these days. Chronic cough. So any condition of chronic obstructive airway disease which causes the raised abdominal pressure. This is very important because not only for the causative, this is a causative cause for this. Secondly, also like before doing any surgery for these patients, we need to control their cough, chronic obstructive airway disease or constipation, so that our results of our surgery are successful. And then so some after hysterectomy, a patient can have wall prolapse also. Smoking, diet, depression may have some, but not definite risk factor. Next, please. Okay, so now we have got a patient. I mean, she complains of urinary incontinence to us. So I'll restrict my talk to stress urinary incontinence because overactive bladder syndrome, my other colleague is speaking. So in overactive bladder syndrome or urge incontinence, is like patient has urge to go. Okay, so that is different topic and that will be covered by others. So I'll restrict myself to stress urinary incontinence. That means raised intra-abdominal pressure or cupping, patient leaks urine. So what is most important for the postgraduates and others, that or clinician approach to a patient. So this is very important to take detailed history of these patients, any review of symptoms, how often, how much, aggravating and improving factors, usage of pads, effect of symptoms on the quality of life, how much it is affecting her quality of life. She has to use pad. I had a patient who can't even, go to any marriage, any party because she leaks urine and she has to wear. Another patient, she has to wear, sanitary pad. Another patient, she has to wear just like the children wear, something like that. No. Then storage symptom, any frequency, urgency, nocturia, voiding symptoms, hesitancy, slow stream. Then past medical history, I mean, patient had any diabetes, pulmonary disease, neurological disease, vascular disease, not only in the past, but current also. This is important because I have seen patients with neurological disease, like, one patient had multiple sclerosis, another patient had, some other neurological problem. One girl, she was a dentist herself. She was operated for meningomyelocin in the childhood. So those are the cause. They can be the cause of incontinence, and then the management is different. I mean, never operate on those patients for like by the tape and all. You have to first treat the medical disorder. Drug history is very important. Many times I see patients, because whenever they are hypertensive patients, they are put on diuretics by our colleagues from medicine and all. So, and by just changing the diuretic to, another antihypertensive drug made the trick. So this is important. Similarly, antipsychotic drugs, anticholinergic drugs. So this detailed history taking is very important. Past surgical history, treatment for incontinence, any surgery she had in the past, menstrual history, obstetric history are routine for this. So what I want to highlight is that the detailed history taking about the symptoms, any past medical history and surgical history, and any drug intake is very, very important for this patient or other like neurological disease, etc., because they may be the cause for that. Next, please. Okay, and same way when now we examine the patient thoroughly, general physical examination is important, and then any in neurological examination also is important for these patients, because sometimes you can have. I had a patient who had abnormal gait, and then there was a lump on her spinal cord, so that is important. Then on abdominal heart chest examination, of course, routinely, and then on abdominal examination, any mass impinging on blood. I've seen 3 patients in which there was one retroperitoneal mass, another big fibroid, another abdominal mass. It just pushed whole uterus down. It also pushed the bladder down, and patient had cystocele and all. So when we did the surgery for her, we did that from above, plus we did her gallistectomy and repair from below. So that is important. Any hernias, any over-distended bladder, and pelvic examination, any excoriation, prolapse, atrophy, torn of pelvic muscles, demonstration of leak, cuff stress test, Boney test, we'll be doing that. So this is important. Like when we are examining, stand on the side of the patient, do local good examination, and then look for the ask the patient to cough, examine her with full bladder. Ask her to cough, so she will leak urine, that means stress urine incontinence. And we put 2 fingers parallel to that and raise them. Then patient doesn't leak urine, this is Boney test positive. That means the Burns corpus surgery is going to be helpful for her. And then now I already told you neurological examination is important. Urine analysis, any bacteria, hematuria or glycosuria, and any culture, because sometimes urge incontinence can be, the symptoms can be of urge incontinence in UTI also. And then cystoscopy, MRI, CT routinely are not recommended, only selected patient, and any residual urine or urodynamic studies only selected patient we do. Next, please. Yeah. Next slide, please.
Yeah.
Okay. Okay. So what we can do a paired test. Like we did a thesis, my postgraduate did it. So we used to give pad to the patient, and then we weighed the pad before and after. Like we asked the patient to drink about say 200 ml of water, and then she walked for about 15 minutes, and then and then after 2 hours we checked the pad again, and we weighed the pad before and after. So any range in the weight of by 1 gram, so that she had incontinence of urine. Dye test usually we don't do unless we are suspecting like any fistula. Next, please. Okay. Yeah. So then cuff stress test, I already said this is to done basically. Stand on the side of the patient with full bladder, ask her to cough, she will leak urine, and then on pressing it doesn't leak. So that means elevation surgery of Burns will going to be helpful. This is the positive Boney test. Next, please. Yeah. You can do Miyazaki Boney test, in which we took 2 basically sponge holding forceps, and we raised the anterior vaginal wall supralaterally. So that is more in direction to Burns corpus suspension. So that can also show the favorable outcome with Burns procedure. It's just like Boney test only. Next, please. Yeah. Next slide, please. So, okay. Causative test just to show the urethral hypermobility. Any basically more than 30-degree angle is hypermobility. So that patient with tape or Burns will be helpful in this patient. Next, please. Okay, a pediatric Foley test is just like this for cervical incontinence, same way we can do. So if your number 8 Foley's catheter can be without inflating the bulb, can be easily withdrawn without inflating the bulb, then it is intrinsic positive. That shows poor estrogenization, and in these patients, basically like good outcome comes with corpus suspension. So we don't normally do this test because sometimes Foley test, you are forcefully pulling it out through the urethra, can cause urethral injury. So I avoid doing this test, but this is recommended, like mentioned in the test. Next, please. Okay, so this is the bladder diary. Simple, I mean, 48 hours or 72 hours bladder diary instead of doing 7 days diary can be good enough. This is very important because this concept is going on. Some lady drink 2 liters, 3 liters, 3.5 liters of water every day. They feel that water is good for their skin. It will make their skin glistening and all. So but I feel that excess of water can make them incontinent. I had at least 3-4 patients, madam, when I just did their menstruation diary, and I found they were drinking 4 liters, 3.5 liters of water every day or other drinks. So when I told them to restrict to 1.8 liter, which is the requirement for our body, their incontinence disappeared of its own. So without any medical treatment. So that is important. Please, the excess of, they need 1.5 to 1.8 liter. So see, and then another thing is what any special drinks make them incontinent also. I had a doctor like she couldn't drink a single cup of coffee. She said, I will pass urine for 5-6 times after that. So someone may have with Coke, someone may have with caffeine. So we need to find our own urinary irritant. That is very important. And then we avoid those food and ask the patient to find. Next, please. Yeah. Okay. Now, urodynamics are not routinely done for all patients of stress incontinence or urge incontinence. ACOG clearly says that, but only indication is that it's a complicated incontinence, failed surgery, or mixed incontinence. Next, please. Yeah. Or treatment failure. So this is the usually, I have already said. Next, please. So NICE and ACOG doesn't say. American College says preoperative urodynamics are not recommended for an uncomplicated SUI who desires sling surgery. So before doing biosculpal suspension or TVT, I don't do routine urodynamic on them unless they are complicated cases or previous failed surgery. American College also doesn't recommend. Next, please. So that will save the patient the time. But if you have to do, you can do uroflowmetry, cystometry, usal function and wording cystometry. So I won't go into detail of that. Next, please. About urodynamics, only selected patient you need to do. Next, please. We know that. Yeah. So this is how it looks like. Next, please. Okay. These are the pressure measurement we do. Next, please. So I won't go into detail of that. Yeah. Next, please. Just that's the. So this slide I want to see the residual urine now it used to be less than 50 ml, but latest they say less than 80 ml, and first desired toward 150 to 250 ml, cyst capacity 400 to 600 ml, maximum detrusor capacity less than 15 centimeter of water in filling phase and 70 centimeter of water in diuretic phase. Peak flow rate is 15 ml per second. Next. No. So now we have made the diagnosis. Usually diagnosis can easily be made from the history taken and examination and bony test. We don't have to do urodynamic studies, but doing a culture or urine examination is good to rule out any UTI. And there was 5 minutes. Then any we do start with the non-surgical treatment, ma'am. But in general, first thing you should with the patient spend about 10 to 15 minutes with the patient. Tell her that she has to do lifestyle changes. That means to lose weight. We'll be doing that. Pelvic floor muscle training. Drugs are there some, and devices usually don't work, but they are mentioned in the literature. Bladder drill and biofeedback, and then of course surgical management will be colpo suspension, sling surgeries. Just to complete the list: needle suspension, anti-colporaphy, peri-urethral injection. This is the gross all treatment. Next, please. I'll just quickly go through it. So what I do that initially for 3 months. Usually as a general principle. For stress incontinence, usually surgical treatment is required for moderate to severe incontinence, but mild to moderate can respond to lifestyle changes also. Lifestyle changes are like weight reduction, decreased caffeine or tea intake, fluid restriction, and bladder training, which I already told. Next, please. So in physical therapy, the Kegel exercise, or we know that to restore the muscle tone and strengthen pivococcygeal pelvic muscle. I won't go into detail. All of us know Kegel exercise, but what is important is that about 15 minutes in the morning, 15 in the evening, and she should contract the muscle. You can while you are doing vaginal exams, ask the patient to squeeze your fingers so that she contract the right muscles. So that is important, and we do give it at least a 3 to 6 months time is given before saying that they have failed. Usually exercises are good, so for mild to moderate they work. So next please. So we encourage that, and then there is level 1 evidence that this pelvic floor muscle training helps. Next, please. Okay, you can use biofeedback also along with that just to so that patient is contracting the right muscles, but not a must. Next, please. Okay, vaginal cones. We don't use in India, but the cone basically is like cone tries to fall down by gravity. But while the perineal floor muscles contract and the levator muscles contract to keep it inside, so gradually we keep different size and increase the size of the cone, and that is done, but not easily available in India, and they are expensive, so not very commonly used. Next, please, just to complete the list. Electric stimulation against to stimulate the perineal muscles. This thing are not very commonly used, but yes, can be. Yeah. Next, please. again to basically contract the muscles. Devices are not really very helpful, but that this URH ring, incontinence test and all, but unfortunately they're not very recommended routinely and not really very effective. Next, please. Okay, again, medical treatment is not very effective for stress incontinence. It is very effective for urge incontinence, that my colleague will be saying later on. Estrogen don't work, but duloxetine is the only drug. And sorry for the dose. Doses should be 20 to 40 milligram. Never go 48, is a bit too much. So that not approved by FDA. But I use 20 milligram only once a day for 3 months. So when the patient is waiting for surgery, I give her 20 milligram duloxetine once a day, along with pediculated exercises, decrease tea, coffee intake, and exercises, and of course to lose weight. And then assess her after 3 months. If she's satisfied and happy, fine, I can continue the same management. If not, then I go for surgical treatment, which I'll be discussing. Next, please. Yeah. Okay. So these are the adverse effects can be there with this drug, and don't use as a first line treatment, but first 3 months you can try it for the patient of SUI. Next, please. Okay, yeah, and this is, I won't go into detail of that, but yeah, radio frequency energy stream, to be honest, I personally don't use it at AIIMS because they though they help in vaginal rejuvenation and may have some role in case of SUI, but the American college and Australian college have recently found a meta-analysis. They haven't found them very, very useful. So they can be done under local anesthesia. Those people who use them are very fond of them, but my only worry is that it costs 20 to 30,000 rupees and you have to repeat it every 6 months. So how many patients in government hospital, they can't afford that, so we don't use it, but certainly in practice it has some role. Next, please. So just to complete the list, yeah, next please. Same thing again. Yeah. So now basically I tend to, most of these patients will require ultimate surgery, which is a permanent solution. So I mean, I tend to do, Birch corpus suspension for these patients, which can be done by open technique or by laparoscopic technique or tension-free tapes, which I'll be taking. So next, please. Yeah. Okay. So these are the, you can, and some, of course, we can use periurethral bulking agents also. Next, please. Okay, so this is the basically same thing, we have already done that. Basically MMK operation no longer done because it can cause osteitis pubis, so we do burst corpus suspension. Next, please. Okay, so in this diagram you can say patient is put in lithotomy position, assistant stand between the two thighs, we put a Foley's catheter from below, and then assistant holds it on. We inflate the bulb with 8 ml. Now from abdomen I open the abdomen but not the peritoneum. So you can see, and then my finger are stopped. We work in the KO ranges. So slightly, the incision is slightly below phalansteal, just suprapubic. And then we find, you can see this, this is the bladder in the center, and then the bladder neck is there. So urethra is there. So urethra itself is the catheter is urethra, inflated bulb is bladder neck. So we take, and the assistant from below, push one sponge holding forceps and lift the vaginal fornix for me on the left side. So I take a deep stitch with non-adherent with this nylon or proline. So one suture on the left side, very close to the bladder neck, but not in the bladder, not in the urethra, not, and not up to vaginal mucosa, just full thickness of vagina accepting mucosa. So 2 stitches on the left side, and then the assistant will hold, push the right side for me. So 2 stitches on the right side. And then the shape sutures, they are with the needle. Then we put on Cooper's ligament on either side. So that we take in the end. If you take in the beginning only, then it will be difficult to take the second stitch. So basically, that's why it's called corpus suspension. So ultimately, what it is doing, it is bringing the proximal urethra back into the abdominal cavity. By this operation, has got very high success. Next, please. We leave the catheter for about 72 hours. Same thing, basically. You can use 2 stitches or 3 stitches on either side. Permanent suture. Next, please. So it is a gold standard. And it has got, you can do it basically laparoscopically or abdominally also, but put at least 2 stitches on either side. And it has got a very excellent long-term success rate. And we are not using any mesh in this case, so it was never stopped by FDA, and almost more effective than TVT or TOT. So it is coming back into. Next, please. Yeah. So almost 90% cure rate at 1 year, 70% at 5 years. So there may be some wording difficulty in some patient. Sometimes patient may have dead-to-zero reactivity after that. And rarely, because we are pulling things anteriorly, so some patient may come back with enterocele or rectocele, but not on these things. So can be done by laparoscopy also. Next, please. Yeah, again, yeah, same thing. Next, please. So equally good results in, next, please. So these are the various studies which have proven. So then came the tension-free vaginal tape. So you can put in anti-abdominal wall on pressure, but for this you have to use the, cystoscopy. And there is 6 to 8% risk of injury to the bladder. But this has got, it's more useful for basically disease deficiency and all. So, but now, because there is a risk of injury to the bladder and urethra, so now we are using tension-free obturated tape. I'll be showing. Next, please. Yeah, same thing, TVT. So we go into anti-abdominal wall. It is at the, so it basically puts the mid urethra is basically pushed a bit up. So it has got about almost 90% success. Next, please. Yeah, same thing, but there is injury, risk of bladder injury. Next, please. Then is the tension-free TVTO, which we are using these days more often. So it can be outside in or inside out. Yeah, next, please. And no need of cystoscopy. Yeah, next, please. I'll show the better. Yeah. So this is the tension-free obturated tape of Johnson & Johnson. So you can see it's a push and lithotomy position. Make 2 to 3 centimeters on the anti-vaginal wall, separate the vaginal mucosa from the urethra, and then we using this like it's a carry needle. You can see the right side, left side. So we put it through that incision and then bring out the obturator foramen, upper middle part, and about 3 centimeters lateral to the clitoris, just lateral to the crural fold on both sides. So ultimately, the basically sling will sit in the mid urethra of the patient. Next, please. I'll just show. Yeah, this is how the tape is put basically, and this is how the tape will ultimately be there in the mid urethra. So polypropylene mesh, and we just cut it. Yeah. Next, please. So sitting in the mid urethra, so there is no risk of injuring the bladder. Same thing basically, you can say how it looks like. It comes through the obturator foramen, and these are the cut needles basically. Next, please. Yeah. Okay. So it has got, TVT obturator basically has equally good results as compared to TVT, lesser chances of injuring the bladder and this thing. Next, please. Yeah. But yeah, same thing. So almost they are both equally good. You can use either. Next, please. Whatever you are using. Yeah. Next, please. Yeah. Same thing. Only problem is that, the results, Cochrane also showed good results, but because of the scares of the mesh erosion and all, the US FDA gave some warning. They never stopped them. But when I went to UK 2 years back, they are no longer available in UK. And so maybe same thing may happen in India. So that is the problem. Otherwise, they are very effective, very successful. Next, please. Yeah. So then, okay. Yeah. Yeah. Next, please. Otherwise, they are good. So there is the pubovaginal sling, or using the patient's own mesh, basically like a rectus fascia sling, or or fascia letter can be used the patient's own this thing, but slightly bigger operation. Next, please. I'll just show you. So we gave a thesis. We did research. So pubovaginal sling in the mid urethra only, or at the bladder neck. Same thing, just like TVT, but instead of putting the artificial mesh, we are using the patient's own the fascia lata or anti-rectus sheath. I tend to use the rectus sheath basically. Next, please. I'll just show you. Okay, so they are more effective than biological analysis. Slightly bigger operation, slightly more complications, but a patient's own, there is no risk of any erosion because it's the patient's own tissue, free of cost. Only thing, slightly bigger operation. Next, please. Okay, yeah. So this is what you do, just like you are doing Pranjal psychopexy, madam. We may open the abdomen, but don't open the peritoneum. We just cut 8 into 1.5 centimeter rectus sheath from here, measuring it. And then ultimately so is taken, and then we put the patient in lithotomy position. We make a vaginal incision 2.5 to 3 centimeter on the anti-vaginal wall, separate the vaginal mucosa from urethra, and dissect up to inferior pubic rim, just like in TVT basically we are doing. Same thing. And now from above, I will, rectus sheath has already separated and cut. Then I will not open the peritoneal cavity, but I'll work in the cave, just like Burt's corpus suspension. And from above, either you can put a needle, or you can put, I tend to put this basically clamp from above, taking care not to injure the bladder, not to injure the urethra, just like in Burt's corpus suspension we do. And then from below, this tape which we cut, my assistant puts 2 stitches on either side with the Prolene on that, and we dip it into hydrocortisone gentamicin solution, and then my assistant feeds it from below. So ultimately, the mid urethra, basically it is put in the mid urethra, and I pull it above, just like you can see, and then I tie it in the anti-rectus sheath above. But putting an artery forceps there. Next slide, please. I'll just show you. Yeah. Okay, again, same thing. So from below, you can see we put an artery forceps below and one artery forceps above, so that it's not too tight. And then we just tied up those Prolene stitches at end. Ultimately, it sits in the mid urethra, and we tie it to the anti-rectus sheath. But don't make it too tight, otherwise patient may have wording dysfunction. So it's the patient's own tissue, her own rectus sheath, free of cost, and no chance of mesh erosion. Only thing, slightly bigger operation, and you need to keep the catheter for 72 hours or so. Next, please. And some of our patients had, same thing. Basically, you can say that I'm putting the tape, tying the knots and step down. So it's in mid urethra, just like it's like TVT only, but only thing the patient rectus fascia is being used. It has not been yet tried actually for obturator foramen, because we don't know where to tie it, in the obturator foramen. So that's why only it is equivalent to basically TVT. So we have done almost 25 cases of it. We got very good results. Only thing slightly more complication as compared to standard TVT and all. But gradually, by when in first 2-3 cases we had more problems. Later on, I mean, our results are getting better with time. Next, please. Okay. Yeah. So this is our paper was published in European Journal of Gynae. This is paper you can say. So we did in that case. At that time, we had done 50 cases of rectus fascia sling. Compared them with the 15 cases of vaginal tape, transoperated tape. So both techniques were equally good, but autologous rectus fascia gave slightly better results. No, but both were good. Next, please. And now, same thing basically. So I wrote an editorial in our Jogi journal, autologous facial sling for surgical management of stress incontinence. So this thing is that in case TVT or TOT become non-available, man, it may happen in India also because of the scarce and all. So we have some alternative. Otherwise, when I went to UK, 2 years back, they have forgotten how to do burst corpus suspension, and these they don't know how to do facial sling, rectus autologous, and the TVT was no longer available. So they were not actually offering anything to the patient other than exercise and all. So now we have, even if the patient, this TVT or TOT become non-available in India, though till now they are available. I am using them. In fact, last week only I used. But we are doing burst corpus suspension also, and we do autologous facial sling also. We are doing TVT, TOT also. They are also good. I personally feel they are not bad actually. Only thing, if they are used judiciously and proper company and all, then they are good. But in case they become non-available and all, then we can always use autologous facial sling. So I feel we should have more training for this because it's a little bit difficult area and we haven't been used to do that, but it can easily be learned. Yeah, next please. Yeah. So anti-colporeph is hardly done basically. Next please. It has got poor success rate, but sometimes we can do it. Needle suspension no longer done these days. Needle suspension no longer done. Next please. Just to complete the painful bulking agent, can be sometimes used in the patient collagen tissue and all. They're not easily available in India, and they cost a lot, about 20,000-25,000 rupees, and it ultimately, basically absorbed in 6 months. So you can't afford 20,000 rupees every 6 months. Next, please. So not much role, basically. Yeah. Next, please. Okay. Artificial as a last, it cost 7-8 lakh rupees, not available in India, but as a last resort in those patients who are totally incontinent where surgery fails. Next, please. Almost done. Yeah. Future trend may be there that stem cell therapy may have role in future. They have been used so those patients who have got very poor sphincter and all that in that area, maybe these patients of SUI with very poor tissue locally. So we can inject basically under ultrasound guidance in the sphincter, but this is just experimental, not yet routinely available. Next, please. Yeah. So these are my take-home message. Overall incidence may be up to 40 to 50%. Thorough history taking examination needs to be done, and minimum 3 months of consecutive treatment should be given to all patients with SUI. Burst corpus suspension is the gold standard. Midurethral sling are replacing the other surgical modalities, and these days because of scarce of this slings, tape erosion. So we are using basically you can use patient-owned fascia, and bladder training to be advised, and medical therapy is recommended for some patients, but usually surgical treatment needed for stress incontinence. Yeah, thank you. Next, please. Yeah, thank you very much.
Chairpersons.
Hello.
Yeah.
Hello.
Yes, sir.
Yes,
Am
we
I
are
audible?
Yes, sir.
Yes. We have gone through Professor Sharma's beautiful lecture elaborations, and he has an extensive experience and extensive practice on this subject of urinary incontinence. And sir, we are really very afraid of this mass erosion and all, and you have really elaborated on this autologous. Instead of mass, we can use autologous TVT or TOT. The brilliant elaborations. Thank you so much.
Thank you, sir.
Thank you, sir. Thank you, sir. Thank you.
My pleasure.
Yeah, I think we can move on to the next topic.
Yes.
Yeah, it's my pleasure to welcome for that session, Dr. Prasad Mahar, who is working as a consultant, Barbani, Maharashtra. Sir's interest is in VOH, medical disorders in pregnancy, infertility, high-risk obstetrics. President of Barbari Society since 2020. Welcome, sir.
Thank you, madam. Thank you.
It's my pleasure to invite the next chairperson, Dr. Varsha Suresh Kadam.
Namaskar, faculty.
Yeah, Jasmine Sharma is another chairperson. Welcome, Dr. Jasmine, who is a consultant in Apollo Clinic, Tinsukia, and member of various other organizations, joint secretary of Tinsukia's Urdu Society. Welcome, Dr. Jasmine.
Thank you, ma'am. Good evening, everyone. Thank you for giving me this opportunity to be a part of this webinar.
Dr. Varsha Kadam, I've not introduced. Can you please project her slide? Dr. Varsha Suresh Kadam, who is a consultant obstetrician and gynecologist, Director Kadam Hospital Nursing Home, practicing for the past 20 years almost, presently working as a secretary of Nandad Society, a part of Cultural Committee of AMOGS 2021 and Survey Committee.
Okay, ma'am. Okay. Got it. Namaskar.
Welcome, Dr. Varsha. Over to you, chairperson, so you can introduce and invite the speaker. Dr. Prasad, can you?
Yeah. Thank you, ma'am. Dr. Mangesh Narwadkar, my friend, is MBBS DGU NDNB, consultant at Gargi Hospital, Nanded. His FIGO 2006 International Fellowship on Maternal Health, Diploma in Endoscopy, Germany 2007, and he is organizing secretary AMOGS 2012. It's also zonal coordinator AMOGS 2011-15, and Urogynecology Committee chairperson Foxy 2014 to 2016. Welcome, Dr. Mangesh Narwadkar, and over to you.
Thank you, Dr. Prasad. Can I share my slides now? Good evening, everybody. At the outset, I cannot move forward by acknowledging Dr. Nikki Karam, who is a wonderful teacher, a great mentor, a skilled surgeon from Cincinnati, Ohio, USA. And I have been to his place twice, and whatever I have learned urogynecology only because of him. With this, the AMOGS Medical Disorder Committee, the in charge, Dr. Sneha Buyar, all the dignitaries from the AMOGS Mumbai, and Dr. P.K. Shah. I went to P.K. Shah, sir, for ultrasound training in 1998. So I know sir since long. And this is one of the wonderful topic I've been given to the present on overactive bladder, and which is one of the most neglected topic by the gynecologist and the urologist too. As this is a very highly prevalent condition, majority of the men and women affect, but throughout their lifetime, and it definitely impacts the quality of life. It is a very debilitating condition, and its incidence goes up to 40% after the age of 70. And honestly, nobody treats this condition, or nobody aware, or nobody keen to finding this kind of a situation. Also, what's happened with these patients. The topic is very simple. If you have a patient comes with a urinary urgency, which is associated with a frequency or a nocturia, and if there is a leakage associated with this, and there is no pathology like a urinary tract infection or any other obvious pathology, then this is labeled as a case of overactive bladder. And if it is associated with incontinence, it is called as OAB wet. And if there is no urinary incontinence, then it is called as OAB dry. And this is the simplest definition that you can able the patient to diagnose the patient. If there is a patient is boiling too often, means it's more than 8 times in a day, 24 hours of duration, then it is called as a frequency. If the patient has to wake for 2 times after she sleeps, then that is as a nocturia. But to label this as a part of an OAB, the cause is often multifactorial. and there is a sudden compelling desire to pass urine, which is difficult to defer. Patient has to go to the bathroom by any means, then this is called as urgency. We get the urge to pee, but that is a normal. But if you can't hold it or you cannot able to defer it, then it is a pathologic. And if it is associated with the involuntary leakage, then it is urinary incontinence. So even patients who suffer from this OAB manage themselves by avoiding frequently. They reduce to they take a very less fluid, and ultimately that they will end up into urinary tract infections. They wear pads or dark clothes to avoid such an embarrassment. They use deodorants, perfumes, and they avoid lifting or bending forward. Nearly the 2/3 of the patients symptomatic before come to our clinic. 30 patient who comes to our clinic, we do ask questions, but we hardly give any kind of a relief to them by prescribing or advising some sort of advice. And almost 80% of the patients are not examined by us. And we are like an industry-driven OBGYNs. Like why I'm saying this, almost the incidence of a Down syndrome is 1 in 600 or 1 in 700, but we spend almost 4,500 or 5,000 rupees of that patient to diagnose one case, and ultimately that the sensitivity of that test is not more than 60 to 70%. So we as a gynecologist should focus on such a condition which is almost 40% prevalent, and we hardly give any relief to these patients. It affects the quality of life. They cannot maintain an independent lifestyle. They have a discomfort. They have a skin irritation because of a urinary leakage. They will depend upon their caregivers. They cannot have a sexual activity. And because of anoxia, their sleep is disturbed. They cannot have a sleep. And because of an urgency and a improper sleep, there is always a risk of fall while they go to the bathroom. So self-confidence, and there is a feeling of shame and embarrassment, and they say that their life is being ruled by bladder, so they have a fear of losing control. Hello, why there is a sound which is continuously? Can you mute the? Hello.
Yes, sir. Yes, sir.
There is a constant disturbance.
Oh, it's fine, sir.
Okay. And there are certain barriers for the treatment because we are living in a society where the patient thinks that it is a process of a normal aging, or they are going to have this whenever they grow old. And sometimes they think that the situation is not very severe, or they're not enough to go to the doctor. Some people feel that they're embarrassed to discuss such a situation with their gynecologist or urologist. And sometimes the treatment won't help. And this was a partially true statement before 2019, where the availability of a beta-3 adrenergic agonist. Previously, the treatment was not very successful, and most of the treatment, the drugs which are associated with the side effects which are very bothersome. So ultimately, there was a discontinuation of the treatment, even though we prescribe a treatment. So this situation was like before 2019. Now that they drastically changed the situation. This is the kind of a process which happens in a patient. So normally what happens, we do get indication at around 150 or 200 ml that we need to go to the bathroom. But we defer that, and the bladder pressure is maintained at a very low. And after when the bladder capacity reaches up to the 400, and depending upon voluntary control, we try to avoid. But this deferment at 150 or 200 is not possible with these patients. So they want to try to go to the bathroom. They just evacuate their bladder. And this cycles happen more frequently. So that is why we called it as a frequency. They have to go to the bathroom very often, more than 8 times in a day. There are certain risk factors like immobility, the cognitive function status is altered. There was some CNS problem like stroke, a patient who is having a diabetes or a lumbar disc disease or a constipation. And there are conditions like urinary tract infection, use of drugs, multiple vaginal deliveries, and the obesity do contribute to the enhancement of an overactive bladder. we have to, while we are taking a history, we have to take a history in details about what are the medications they have, and these are the one who likely to worsen the OAB symptoms. Now, this is one of the very simple and effective slide. OAB is a clinical diagnosis. You can, and second thing is you can treat it in your clinic. These are the two important statements. And how do you know that? It is a simple screening questionnaire, or if you can ask 2 or 3 questions to the patients. Do you have any voiding problem? And do you ever leak? And with these 2 questions, then you can take a detailed history, and then that will lead to the diagnosis of OAB in almost 40% of the patient. And as I said, it's a clinical diagnosis, and there is a patient who have an urgency, frequency, and nocturia in the absence of clinical pathology. Means you have to take a history to know either any associated causes or any CNS causes or any previous urinary tract infection. Then you have to do a thorough physical examination to know for any mass or there is any prolapse, or is there some neurological problem. If you find a problem in a speech or a gait, then you can involve your neurologist to find out what is the problem. You can do a simple urine analysis and urine culture. And there are certain tests like in each and every patient, we do ultrasound. And that time, if you ask them a specific information like a post-voidal residual, that will also give the idea. And cystoscopy and urodynamics requires in very few cases where you are not very sure of that it is a mixed incontinence or some other problem. But this is a clinical diagnosis, and generally we have to ask for a bladder diary for at least 2 days or 3 days. That will give you an idea that they are having some problem, and then you can treat this. With this, you are pretty much sure the patient is having an overactive bladder, and I can give you that whatever the panelists among here age more than 60, I can say that there are almost 40% have some of the problem of an urgency, frequency, or nocturia. So, and one of the problem in this medication is that, or any treatment advice, that here we cannot talk of cure. We only concern about how we can improve your quality of life by reducing your incontinent episode, or how can we keep you dry so that will help them to mingle with, or they have a social life, or they have their personal life, or they can go with the better quality of life. So it's a patient's education, and it's an improvement of the quality of life with the patient goals and expectation. Apparently, this healthy lifestyle it's okay with each and every disease we have. So even at 5 to 8% of weight loss is going to decrease their incontinent episode. They have to alter their fluid intake. So the people do have a habit of taking more than 8 glasses of water in a day. So we have to know that whether they are drinking excessively by doing a bladder diary. And they should be avoided that they should restrict slightly fluid in the evening, or they cannot drink a fluid after the dinner, so that they can have the proper sleep by not wake because of less nocturia. And there are ways to control urgency or frequency that we can be, with the help of a physiotherapist, we can treat them. And this is one of the most important area. It is, again, I said it's neglected. We never ever prescribe local estrogen to any postmenopausal women. And to avoid the urogenital problems, a postmenopausal patient, we have to offer estrogen, and that will help to reduce stress incontinence. They can have a better sexual life, and the OAB can be reduced. This is a very simple: give the estrogen for 14 days prior, one applicator a night for 14 days, and then twice weekly for 1 year. And depending upon the further need, you can continue or discontinue. And as I said, with this kind of changes, we can expect an almost 25 to 30% improvement in their life. And then at this moment, we can add a medication. Only medication or only physiotherapy is not going to help. So the combination of physiotherapy and the medication will definitely bring about a better change in their life. Now, if we want to prescribe medication, if you understand this slide and then next slide, then that the life is easy for us also and for the patients also. This is a detrusor muscle where muscarinic receptors, M2 are more than 80% and M3 is 20%, and the beta adrenergic, so the detrusor muscle. If you're able to understand this slide, then it is, I can give you the explanation in next slides. And there are multiple muscarinic receptors, M2 in the bladder, M3 in the bladder and secretory gland, and rest of the others in other like M1 to M5. If you, why that there are complications or there are side effects? Because of this, drugs are not very selective, so that the patient will have, these are the side effects. So whatever what choice we have, it's a beta-3 adrenergic agonist. This is one of the game changer medicine which has came in, although it came in the market since 2012, but it is freely available in India since 2018 and 19. And previously we don't have any other choice prescribing anti-muscarinics. And these are agonist acts by stimulating beta-3 adrenergic receptors, and these are the anti-muscarinics block the muscarinic receptors. They have an almost efficacy of almost 60 to 70, 80%. But once you start any medication, we'll have to wait for a 2 weeks for their response. And maximal effect can be seen in 6 to 12 weeks. We can combine these medication, but only thing that what limits to use of these drugs is the side effects and associated dementia, risk of dementia. As I said, this is a game changer drug. And this is a very exciting alternative to the anti-muscarinics. It acts on the beta-3 receptors of bladder dome, and that causes a detrusor relaxation. And because it is a very specific drug, it's not acting on muscarinic receptors, so lower rates of dry mouth, constipation, headache. So that is better drugs compared with an anti-muscarinics. There are two drugs which are available, mirabegron and vibregron. Mirabegron is available in India very freely. The cost of treatment is not more than 750 to 900 rupees a month. Vibregron costs 1800 or 2000, but it is still not freely available. Only thing that the Vibregron can be given with the food after crushing it out. And mirabegron cannot be prescribed to the patient who have hypertension, uncontrolled hypertension, or who have recently developed hypertension once we have prescribed mirabegron. And only 2 to 10% of a discontinuation rates because of side effects. And compared between these, Vibregron is much better, but we can still do wonders with mirabegron. So only thing that the Vibregron is slightly costly. And these are the anti-muscarinic drugs. Almost 7-8 drugs are there. To my knowledge, it is whenever there are multiple drugs are available, means it is either drug is not very good, or it's not very effective, or it's associated with a side effect. So that is the clinical scenario happens, and each drug affect differently. Why? Each drug is very selective or it is non-selective, and depending upon that, the predominance of side effects can be expected depending upon their actions on particular receptor. Anti-muscarinics are contraindicated in cases of a tachyarrhythmia, myasthenia gravis, gastric retention, and narrow angle glaucoma. Unless until we do have our physician colleague with us, we cannot able to diagnose these conditions. So it is, do take an opinion from your physician. As I said, because it's not a very selective drug, it affects all the other muscarinic receptors, so that we have to expect other side effects like dry mouth and constipation. And there is always a risk of a dementia, which is more than a 65%. So if you want to prescribe in an old age patient, so we have to take a due consideration and a proper precaution. As I said, it's causes every anti-muscarinic causes dry mouth and constipation. All crosses the blood-brain barrier, so we have to be cautious. And long-term adherence to the anti-muscarinics is very low. And all full continence means it's a patient who is completely dry in only 30% or 25% of the patient. But there is always a risk of a retention. So we might have to do self-catheterization, or patient has to be taught regarding self-catheterization also. Now, there are certain important tips prescribing anti-muscarinics. I'm not saying if you are tuned or you're very keen on using anti-muscarinics, then the trospium and darafenacin is the better choice, as they cause less effect on a cognitive function. We have to wait for 4 to 6 weeks for a maximal effect. Till that time, you can go up to the maximal dose. A patient who do not have a relief with one anti-muscarinics can be switched over to the another anti-muscarinics. And as I said, it's a selectivity will be different in each anti-muscarinics. So they can be treated with other anti-muscarinics also. Immediate release formulation will cause side effects or more. So it is always preferable the extended release for drug formulations. And because of the side effects, you should titrate the dose accordingly, and you can slightly go on gradually increasing the dose accordingly by looking at the side effects. And these are the drug anti-muscarinics do have interfere with the drugs of, or the other drug will interfere with the actions of anti-muscarinics. So we'll have to take a precaution while looking at the drug history, and then we have to titrate, or we have to be judgmental regarding which drugs to be prescribed. And as I said, it's a game changer. Why? Because by the age of, by the 6 months or 1 year, only by the end of the 1 year, only 36% of the patient who was on our anti-muscarinics have continued their drugs, because majority have stopped their drug because of their side effects. And only reason is that they have a dry mouth. And to compensate the dry mouth, they used to drink water, and then this will worsen their incontinent period, and constipation is another reason for discontinuation. So we have a choice between beta-3 adrenergics and anti-muscarinics. So start with an beta-adrenergics. If you want to want a better control, then you can add a solifenacin, darafenacin to that, and gradually the patient will get the maximal effect with these two drugs. Suppose these two drugs don't work, then these are the one we can try as a third line management. It's a percutaneous tibial nerve stimulation, intradetrusor Botox injection, or sacral nerve stimulation. This is a treatment where electrical stimulation therapy is there. We have to place a needle just above the medial malleolus, 5 centimeter, a 34 gauge needle, and this will stimulate the L4 and S3 nerve roots. The patient has to come for 30 minutes on a weekly basis for 12 weeks, and subsequently monthly treatment. Only 71% have completed by 12 weeks. Only 30% achieved success by 8 weeks, and 41% by 12 weeks. So it is not that very effective treatment, but if the drugs are not working, then this is the better alternative to treat these patients. And it's hardly it's not associated with great morbidity.
Initially, we will demonstrate the technique.
This is a intradetrusor injection of a Botox, which is to be given by a cystoscopy. It paralyzes the detrusor muscle. Its effect lasts for 6 to 12 months. Then we'll have to repeat the injection. But this is a surgical process, and we have to inject almost 100 to 200 units of a Botox intradetrusor. The action starts within 2 weeks, but the duration is working effective for only for 3 to 12 months, and we need to repeat the injection every 9 to 12 months. So the maximum Botox can be used as 400 units in a year. And as I previously said, when we are doing some uterine bladder relaxant or a detrusor relaxant treatment, there is always a risk of an urinary retention. Then there are real threat of self-catheterization. My patient has to be taught regarding self-catheterization. And as this is an invasive procedure, this leads to a urinary tract infection. So a patient who have a recurrent urinary tract infection, this is the procedure is not rather preferable or not acceptable. A sensory nerve stimulation therapy is one of the electrode is put in at the level of S2, S3, and it has been given electrical signal with a port which is placed in the buttocks, and that has been charged, rather that battery lasts for 5 weeks. But this is a very costly treatment, and which is not available. I have not seen in India people are doing it. It's almost $30,000 to $40,000 in USA, and that comes in a very last like a treatment modality. Before that, whatever the option I have discussed. There are certain number of very few patients where we have done everything, even after a sacral nerve stimulation. There are very radical procedures being described, but honestly, it is very difficult to manage these patients. So, to conclude this topic, is that we should start from an physiotherapy, go for a beta-3 adrenergics, and start prescribing it without any of hindrance. This 900 rupees treatment is going to get wonder. Her quality of life is definitely going to improve, and she will give you blessings for her. And treat explain to the patient that you will not get the full cure. Your quality or your incontinent episode or it will be reduced, or you can able to manage your life better. And combination of treatment plan works. Now I can thank you, Dr. Sneha Bhuyar and Dr. J.B. Sharma to giving me this opportunity to present on a topic which is very interesting, but it is very ignored by most of the people. Thank you very much.
Chairperson's concluding remarks.
Thank you, sir. Thank you, Mangesh, sir. It's always really very nice to hear you, all the updates regarding this OAB. As we belong to same place, Nanded, I have been seeing him since last 2 decades, very academically and practically very sound person. Thank you, sir, once again for these details regarding important tips regarding OAB. Thank you, sir. Thank you so much.
Last comment. I would like to involve Dr. P.K. Shah to comment upon this management of OAB from your point of view.
Expert comment, sir.
Mangesh.
Yes, sir.
You selected wrong person.
Okay.
I think there's a limit for gynecologists to treat certain problems. And I feel it is best that we refer patients to specialists like you and Dr. J.B. Sharma, because all these drugs are quite foreign to us. We don't use it commonly at all. So I personally feel that gynecologists who come across cases of overactive bladder, they should refer the patient to a urogynec or a urologist. But your lecture was superb, and I enjoyed listening to it. It has given me tremendous knowledge, but I won't myself prescribe any drug that you have said. Thank you.
Okay, sir. Thank you. Thank you, sir.
Thank you so much, Shah, sir, for your comments. It has got more value. Thank you so much.
Thank you, Mangesh sir, for a very extensive and descriptive presentation. And now there is a slight change in the program. Instead of Dr. Sneha Bhuyar Madam's talk, we are going to have Dr. Saswati Kanyal Chaudhary's talk. So for this, I invite for chairpersons, Dr. Kishore Atnurkar sir, Dr. Nilakshi Fukan, and Dr. Deepti Goswami. So is Dr. Kishore sir here? I don't see him in the group right now. So yeah, you can show the slides. I will read it out. Yeah, Sahiti, you are correct. Yeah. Dr. Kishore Atnurkar sir is a consultant in private sector. Yeah, he is there. Thank you. He is for the last 34 years. He is president of Nanded OB-GYN Society. Areas of interest is cesarean section, population control, sexuality in adolescent girls and boys, pre-marriage and pre-conceptional counseling. He has documented more than 10,000 cesarean section cases in last 23 years and presented 4 scientific papers, written a book in Marathi on different aspects of women's health, which even I have with me, written small booklets giving minimal essential knowledge of commonly used contraceptive methods in Marathi, Hindi, and English. Titles are Nirnay Tujhe Majha, Hamara Nirnay, and Together We Decide. Congratulations, sir, for such nice books, publication of such nice books. And I welcome you to this webinar. So can I have the next slide? Dr. Nilakshi, she is a very good friend of mine. She is consultant at Downtown Hospital and Dr. K.C. Das Nursing Home at Guwahati. She is visiting consultant at Pratiksha Hospital, Guwahati, director of Gynec Center. Presently, she is president of Guwahati OB-GYN Society. She has been former secretary of IMS Guwahati chapter, founder president of Guwahati Menopause Society. She also has been joint secretary of AICOG, hosted by Guwahati Society, and has been invited faculty in many national conferences, and works with NGO working on cancer awareness in women of Northeastern region. So can I have also Dr. Deepti Goswami CB, because she will also be sharing. Yeah, because we are merging. Dr. Sneha madam may not be able to speak now, so yeah. So welcome Dr. Deepti Goswami. She is a gold medalist and she is doing cosmetic gynecology, senior consultant in obstetric and gynecology at Dispur Polyclinic and Hospitals, and presently she is secretary Guwahati Obstetric and Gynec Society. Welcome, Dr. Deepti. So all the chairpersons are here. So I request Dr. Nilakshi to introduce Dr. Swati Sanyal Chaudhary, madam.
Thank you, Dr. Suman, for your kind introduction. And it's a real pleasure to be a part of this wonderful CME. So now my job is to introduce Dr. Shashwati Sanyal Chaudhary. I don't think she needs much introduction. She is well known to this in this platform. And presently, she is a professor in the Department of ONG Guwahati Medical College. She was chairperson in Medical Education Committee FOXIC from 2013 to 2015. She is a vice president ISOPAB 2020-22. The president ISOPAB Assam chapter. She is a vice president, past president GOGS. She is a member of editorial board of New Indian Journal of OBGYN. And I know that whatever topic she is going to speak, it is very close to her heart. Ma'am, the platform is yours.
Thank you, Nilakshi, for those beautiful words. And I thank the organizer who has allowed me to be a part of this particular conference, especially Dr. Sneha Bhuyar. So yes. So what I'm going to speak is around, everybody knows, I think, around this, but I'll just go on. What is its role? Aspirin, heparin, and arginine. These are the 3 things. I want to know, is there any evidences that has come out recently? And I'll mention that preeclampsia as gestosis. So we all know that the basic pathophysiology of gestosis is the vasospasm, endothelial cell dysfunction, and there is inflammation leading to activation of and coagulation.
Please make full screen. Gaiti?
It is full screen. I have given it full screen.
No, ma'am, the slides are not in full screen, ma'am.
I've given it to the full screen.
You can make
your kindly reshare it, ma'am, or else I will share from my end, ma'am.
Yeah, that also you can do.
Okay, ma'am. I'll share from my end, ma'am.
So what I am supposed to do? Stop sharing.
Yes, ma'am.
Yeah.
Is it visible, ma'am?
Yeah.
You can just tell next, so that I'll go to next slide.
Oh, I have to take them. Yeah. So that is the basic problem of gestosis. I have already talked. Can you go to the next slide, please? So there is an early onset cases. You have the maternal vascular malperfusion, which leads to excessive anti-angiogenic factors, increased systemic vascular resistance, and a reduced cardiac output and stroke volume and relative bradycardia. But in late onset, there is less severe placental disease and less changes in the angiogenic proteins. Influenced by maternal factors, there are features of metabolic syndrome, exaggerated hemodynamic response to pregnancy. So this is the early onset feature which we are, very much concerned about. Next slide, please. Next slide. So let's go to the aspirin. I think this is, we do not have any confusion regarding aspirin. It was there for such a long time, since 1986. This study was done by Wallenberg from 50 milligram, 150 milligram, and they have shown that it effectively inhibits platelet thromboxane A2 biosynthesis, and it has a minimal effect on prostacyclin. Next slide, please. So this is a collaborative study, Paris, in 2007, which was a meta-analysis of 32,000 women. And they have shown that there was 10% reduction of preeclampsia, superimposed preeclampsia, preterm birth, and adverse pregnancy outcome. Next slide. And this is 2012 by Robert meta-analysis, and also Villa 2013. And they said that there is marginal benefits for prevention of severe disease. Next slide. This is in 2017. We have 1,600 women from 11 to 14 weeks till 36 weeks. Aspirin was given in high-risk women for preterm preeclampsia, and the rate of the recurrence was only 1.6% in the treatment group versus 4.3% in the placebo group. I think 4 times more common in the placebo group. Next slide. So this aspirin, they say that before 16 weeks, there is 60% risk reduction in the preeclampsia and fetal growth restriction. And it has also showed dose response effect. Next slide. This is we have that landmark trial of aspirin in 2017. And ASPRI stands for Aspirin Evidence-Based Preeclampsia Prevention Trial. And they have included here 26,941 women. This is a randomized double-blind trial. And they are given 150 milligram per day between 11 to 14 weeks till 36 weeks for high-risk women for preterm labor. And they could show an reduction of preterm preeclampsia by 62%. Remember this is the early onset preeclampsia that can be reduced by giving this aspirin. Next slide. And US Preventive Service Task Force, they have recommended that low dose aspirin prophylaxis should be given for the high risk group. And ACOG 2016 recommends low dose aspirin between 12 to 28 weeks for prevention in patients with previous history of same disease, twins, chronic hypertension, renal disease, and autoimmune disorders. And ACOG probably they give 81 milligram. And next, let's come to about the heparin, the low dose heparin. This is a second line of therapy, augmenting the protective and therapeutic effect of aspirin. Multiple trials were given which reduced preeclampsia and fetal growth restriction, that is less than 5th percentile. Next slide. This is a 2016 studies, a meta-analysis on low-dose heparin, where they have shown 963 subjects. There was no difference of recurrence, abruption, or fetal growth restrictions with placebo. This study does not show any good effect of heparin. And this is again another study, meta-analysis, multiple studies, they have done a meta-analysis. They have shown that heparin versus no heparin, of course, low molecular heparin, the p-value is 0.11, which is not significant. But they say maybe a subgroup of at risk of early onset disease associated with placental and maternal cardiovascular dysfunction may benefit of low molecular weight heparin. Next slide, please. So these are the two trials, the HEPP and the EPPI trials. They have given enoxaparin with aspirin. They say that does not reduce placenta-mediate complication when compared to ASA alone. Next slide. So the potential mechanism, they thought it is probably that there is no anticoagulant effect within the placenta, but in vivo it exerts beneficial action directly on the maternal vasculature, that is in blood pressure, good endothelial function, and modification of angiogenic factors in positive manner. And in vitro, there is a beneficial effect on the vascular reaction and endothelial function. So there is a modification of angiogenic factors, probably they can have some effect on the onset of preeclampsia. Next slide, please. So the reasons they have said that acute impaired endothelium dependent relaxation in the pregnancy with high risk of severe preeclampsia and significant increase in PLGF. If you give aspirin, the heparin and aspirin together, there is an increase of PLGF. So you have to select the patient you should select those patients with the highest risk for early onset disease. This is characterized by low cardiac output, endothelial dysfunction, increased peripheral resistance, and with abnormal level of PLGF. So probably these are the group of patients where they can have good effects. So if you do a meticulous selection of the patient, low molecular weight heparin significantly reduces the primary outcome compared to no low molecular weight heparin. And they show that it is 8% versus 27%. So the conclusion was that it is beneficial to the patient who had a previous history of preeclampsia, pregnancy loss, small for gestational age, and the history of abruptio. This is a single central trial. The Cochrane says the heparin is to be considered for high risk of adverse pregnancy complication, secondary to placental insufficiency, was associated with significant reduction in perinatal mortality rate, preterm birth, and low birth weight when compared to treatment. Next slide. And ISUOG also said that if there's a history of preeclampsia, low molecular heparin and ASA versus only ASA was associated with significant reduction in the development of preeclampsia and delivery of SGA babies in true trial. But this is not for recurrent miscarriage. This is only for preeclampsia. So conclusion, we actually need well-conducted, multicentric, bigger trials like ASPRE trials, huge number of patients to be for further recommendation. Next slide. So the list comes to L-arginine. Now this is a study in human hypertension where they have 84 women at risk, and they found there was an association of reduction of preeclampsia compared with placebo, and also reduction in preterm birth, and also in patient with known hypertension, there was a reduction of incidence of superimposed preeclampsia. Next slide, please. So what is the mechanism? We know that nitric oxide is a potent vasodilator. There is inhibition of thromboxane A2, stimulation of prostacyclin, inhibition of platelet aggregation while reducing reactive oxygen species free radicals and oxidation of LDL cholesterol. And endothelial dysfunction and impaired nitric oxide synthesis and its bioavailability is one of the hypotheses for the development of preeclampsia. Now, production of nitric oxide regulated by methyl derivatives of L-arginine, especially ADMA, active. This is an active inhibitor of nitric oxide synthase. Next slide. So insufficient endogenous production of L-arginine preeclampsia, that is the insufficient production of L-arginine, ratio of ADMA to L-arginine is more critical, and nitric oxide synthase activity and the production of oxygen-free radicals and nitric oxide synthase dysfunction. Next slide. So the dose is around 3 to 14 milligram daily orally. The IV also tried, combination of oral and IV, and this is well tolerated. There are no significant adverse side effects like dyspepsia, nausea, dizziness, headache, and palpitation. These are the minor side effects that we can come across. And this is another study in 2018, 3 years interventional cohort study in 3 groups. And 3 gram BI in group 3, it was given 3 gram BD till delivery. And level of nitric oxide was analyzed at 11 to 14 weeks of gestation, and again at 17 to 22 weeks of gestation. And they show that increased blood level of nitric oxide, and there is a significant lowers the incidence of preeclampsia, because they have shown that 37.7 versus 89.6, the chance of gestation with or without L-arginine. So this is in one small study. Of course, it's not a very big study that has shown there can be some effect of this. But again, arginine doesn't have much more side effects. Next slide, please. This is the Journal of Hypertension in 2016. They said it is safe and effective. It prevents preeclampsia. Absolute risk reduction is risk ratio is 0.74. There's lesser chance of preterm birth, and as well as birth weight is also higher. Next slide, please. So the take-home message: aspirin, it's yes. High risk group. The dose is 150 milligram daily till delivery. That is what evidence says. And I have seen a question in the chat box. So the answer to this is 150 milligram. And low molecular heparin, probably in a special group with autoimmunity in combination with ASA, is better. And L-arginine maybe, but it does not have any harmful effect. So thank you so much for a patient hearing.
Dr. Kishore Atnurkar sir to conclude the topic.
Yes, thank you very much, madam. You have given, the role of aspirin, L-arginine, and low molecular weight heparin in the treatment of preeclampsia in a very short period of time. You have explained many things, and the take-home message is very clear to all those. Only the question which I want to ask is she has advised to give 150 milligram of aspirin till delivery. The common practice we do is to stop aspirin at the time of, at
36 weeks.
Or 36 weeks.
36 weeks. That is what we do, 36 weeks.
In your slide, it was till delivery.
Some people, they say till can be, but the other slides that I have shown that the most of the studies they have given till 36 weeks.
Okay.
Because severe preeclampsia, most of the cases they will land in, you have to do some intervention, maybe before 36 weeks also. But aspirin doesn't have a much problem. Even the anesthetist, they say aspirin is fine, because a lot of patients, they do deliver even with aspirin, and that is not, it doesn't have going to be any bad effect on this. So it's not that if the patient is on aspirin, you cannot deliver the patient, you cannot do cesarean section. So that can be done. But 36 weeks, that's what we practice. Dr. P.K. Shah, nice to see you. Sir, I want your expert comment on this.
Sir, unmute yourself.
Unmute, sir.
Yeah.
Seeing you after a very, very long time.
Yes, sir.
And it was an excellent talk. Covered
Thank
everything.
you.
And I fully agree with you and Dr. Kishore that there are so many papers now that say that it can be continued till delivery. Though we all stop in our practice after 36 weeks, there are papers that say that it doesn't have any harm, because the dose that we use is hardly 150 milligram, that is low dose aspirin. So it doesn't have deleterious effect on pregnancy, causing accidental hemorrhage, etc., or PPH. So I think you can continue, but to be on safer side, as an obstetrician practicing for such a long time, I stop it after 36 weeks.
Yes, same here.
There is no need. It is not required after that.
Yeah.
Once the baby is almost mature.
Yeah.
Yeah.
Well, second thing which I would like to tell that where we are practicing, we are using, or all of us, we are using aspirin, maybe in the dose of 75 milligram or 150 milligram. It's okay. But we do not have much experience of using low molecular weight heparin and L-arginine for prevention and treatment of pregnancy-induced hypertension. We do not have the experience. And what I would like to suggest on the occasion of such webinars, after such a wonderful talk by Madam, Amox or Foxy, see, you have shown so many references, Cochrane references, and there are so many international figures, statistics in favor and against of the use of these three drugs. Okay, but in Indian scenario, and we should start, somebody of us should come forward to study our own patients. And Amox or Foxy or medical disorders community can initiate such study and allot 1 or 2 persons per district all over Maharashtra to have double-blind controlled study, or we can have our own statistics and bring forward to the world. That's what the humble suggestion is. You can, if you can, please consider this.
Sir, we use a lot of low molecular heparin for the patients who are APLA positive, and that we are using because APLA patients are also prone to develop preeclampsia. And we are using it and we are happy with it, and we know when to stop it just 24 hours before a delivery. And we must continue it is after delivery, after 24 hours, because I have seen patient developing an SSS thrombosis after stopping it because she didn't take that injection later on. And so you have to know that if somebody is APLA positive, that has to be continued even after delivery. So those, the special cases, that's what as of now the evidence says, that in special cases where there is a chance of this particular thing, then that can be used, but not as a routine for each and every one, the way you are using aspirin for the high risk group, only those. But this is a special risk group where we use the heparin. But for L-arginine, I think there is no harm, and that's what say. Of course, we do not have huge, but Foxy can always take a study on this, that L-arginine, because it is harmless. So that can be also in side by side, that can be used for this. I'm sure it's a very good suggestion by you, sir.
Just to see what is happening in patients which belong to our area.
Yes.
To see and contribute to the existing literature. That's a small suggestion. That's all.
Thank you, sir, for your inputs and questions. And I also request Dr. Deepti Goswami for her inputs. Dr. Deepti.
Yeah, thank you for giving me the opportunity, and it is always it's a proud privilege to listen to the talk of Ma'am Shashwati Sanyal ma'am, because she was my teacher during my PG days. So I've learned so much from her. So it was an excellent talk, and it's always a pleasure to listen to her. And not only her talks, the previous talks were also very interesting. So we learned so much. Thank you so much.
Thank you, chairpersons, and thank you, speaker, Dr. Shashwati Sanyal Chaudhary.
Thank you so much.
So
Thank
now
you.
we move on to the next session, and I welcome Dr. Muralidhar Pai sir. He has already joined, and I'd like to introduce our chairpersons. First chairperson is Dr. Pranay Phukan sir. He is associate professor in Assam Medical College Hospital, Dibrugarh. He is also postgraduate teacher and examiner, ICOG visiting professor, Vice President, Dibrugarh OB-GYN Society. He was previously Vice President. He has also been organizing secretary of Yuva Foxy Dibrugarh. He has been trained in IVF from Boston, USA. He is winner of National Foxy Quiz as postgraduate student in 1988. He is recipient of many awards and accolades. Oceania Young Gynecologist Award he received in 2002. Many publications to his credit, 20 original papers in national and international journals. He is principal investigator in the ICMR project on serum AMH. Contributions of chapters in OG books published by Foxy, He's also peer reviewer of national international journals. Welcome, sir. Can I have the next CV? Yeah.
Dr.
Welcome,
Suman.
Yeah.
Suman. He is an excellent poet. Excellent poet. Yes, that is an extraordinary qualification of him.
Wow. Yes, but he is not, yes, just concealed from his CV. So,
Namaskar. Good evening. Yeah.
welcome, sir. I take the pleasure to introduce Dr. Rakhi Sarda. She is director of Sadasukh Hospital in Latur, Maharashtra. She's been past secretary of Latur OB-GYN Society, practicing in the field of OB-GYN since 12 years. She has special interest in field of infertility and adolescence and has delivered many awareness lectures in schools, colleges, and public places on adolescence, cancer, etc. And I also take the opportunity to welcome and invite Dr. Swati Gaur. Can I have her CV? Swati
Yes,
Gaur?
ma'am. Yes, ma'am. One second.
Yeah. I'm just trying to merge the chairpersons, as maybe we are not able to have the Dr. Sneha Madam's talk. So Dr. Swati Gaur, welcome Dr. Swati. She is director at Gaur Hospital and Maternity Center in Latur, and she is practicing for last 23 years. She has diploma in dietetics and clinical nutrition. Presently, she is president of Latur OG Society and chairperson of Mission Pink Health 2020. She has been organizing secretary for MOX 2022. She has special interest in fetal medicine. So hand over to the chairpersons to introduce our speaker, Dr. Muralidhar Pai, sir.
Thank you, ma'am. At the outset, I'd like to thank Sneha Bhugar madam and Suman Sinha madam for giving me an opportunity for being the part of this excellent academic feast, madam. Thank you so much. Now, I'd like to introduce our today's speaker, Dr. Professor Muralidhar V. Pai, sir. Welcome you, sir, for this academic feast. Sir is a dean at Sikkim Manipal Institute of Medical Science, professor and HOD of OBGY, KMC Manipal. He is a founder and a current chairperson of Karnataka College of OBGY. Sir has 700 guest lectures, 203 publications, 14 best teacher and teaching material, 4 best research awards. Hats off to you, sir, for this. And sir has also been an author for the 4th edition of Holman and Brew OBGY and an 1st edition for Obstetrics and Gynec PMFU. Sir has a 35 years of teaching, 30 years of experience as examiner. Apart from this, sir is also a good singer. Over to you, sir.
Thank you very much, Rekha. And I thank Dr. Suman and Dr. Sneha for inviting me for this talk. Namaste, sir, Dr. P.K. Shah, sir.
Namaste.
Yeah. So, and I would like to straight away go into the topic. And today's talk is on neurological seizure disorders. Whenever we talk about seizure, anytime during pregnancy, we always say that if you have not known the history of the patient, first you have to rule out eclampsia. But today I am not going to talk on that. I am going to talk on a proper neurological seizure disorders. How do they affect pregnancy and how pregnancy affects them and what precautions we have to take. So I want to put this clarity right in the beginning of my talk. Seizure is a paroxysmal, that means sudden onset of things. It's a paroxysmal disorder of the central nervous system characterized by an abnormal neuronal discharge with or without loss of consciousness. In some of the seizures, there may not be any loss of consciousness, but in some, there might be loss of consciousness also. This has to be clearly understood. Now, epilepsy is the common terminology that everybody uses. We need to know clearly what it is. It encompasses different syndromes whose cardinal feature is a predisposition to recurrent unprovoked seizures. The two words important here are recurrent and unprovoked. It's not because of any flashy lights or any sound or any other type of stimulus. It is unprovoked and it is recurrent. So these are the two hallmarks of epilepsy. The incidence, fortunately, is very less, approximately 0.15% of all pregnancies. However, in India, we must be aware that 40% of epileptics are women of childbearing age. So we should be aware of this particular stats. Nearly 2 to 3 million potential mothers suffer from seizure disorders. So even though this is not the commonest topic that is discussed in conferences, CMEs, and symposia, I purposely chose this topic because once in a way we must know about some rare problems. The classification, typically we say focal or generalized. Then there is, of course, absent seizures. Focal means they have origin in one area of the brain, obviously affect a corresponding area of the neurological function. So it is restricted to one area in the brain and the corresponding area in the neurological function. They can result from either trauma in that particular area or an abscess or a tumor or perinatal factors. Although a specific lesion is rarely demonstrated, though we say it is focal area, but sometimes it may not be readily seen in a MRI or in a CT scan. Generalized, they involve both brain hemispheres and are usually preceded by an aura before an abrupt loss of consciousness. There is no triggering factor, but there is an aura before they get generalized epilepsy, and there is an abrupt loss of consciousness in here because it is generalized. It is hereditary. So in generalized tonic-clonic seizures, we see, as I already said, loss of consciousness occurs, which is followed by tonic contraction of the muscles and rigid posturing. So all the muscles are in a rigid posture, and then followed by clonic contractions. There will be shaking of the limbs and other body parts. Patient gradually returns to consciousness. We have all seen this. Patient will remain confused and disoriented for several hours after gaining the consciousness. This is typical generalized form of seizures or epilepsy. Then there is absence seizures. What is it? It's also called petit mal seizures, a form of generalized epilepsy, but that involves a brief loss of consciousness, not like in general epilepsy, without muscle activity. There is no tonic or clonic shaking of the body parts, and are characterized by immediate recovery of consciousness and orientation. So in fact, sometimes it is very difficult to diagnose a petit mal seizures because they have brief loss of consciousness. Suddenly they'll gain back the consciousness. They're not confused. They are fully oriented, and there is no shaking or of any body parts. Tonic or clonic seizures will not be there, but it is still a part of absence seizures. It's a seizure disorder, but you don't see obvious seizures in this. What are the causes? Head trauma. Of course, in a focal, as I already said, there is a trauma in a focal area, but in a generalized seizure and petit mal seizures, it may be a generalized head trauma or alcohol and other drug-induced withdrawals. We have seen this when there's a drug withdrawal, they have got this kind of a feature which almost looks like generalized epilepsy. Then cerebral infections, generalized cerebral infections may be viral or even bacterial, tubercular or whatever. Brain tumors, which is occupying a large part of the brain, and biochemical abnormalities, and arteriovenous malformations. Then, of course, when you don't find any obvious biological cause, there can be idiopathic that is epilepsy, usually diagnosed by exclusion of all other causes such as trauma, infection, brain tumor, and other arteriovenous malformations and things like that. So what is important for an obstetrician is that, yes, this is a patient who is known case of seizure disorder. So how do we prepare her for pregnancy? Can she become pregnant at all? Yes, of course, we cannot deny pregnancy for any lady, right? So she has the right to become pregnant, but we have to do the proper counseling for her. Women with epilepsy have 2 to 3-fold risk of having infants with structural abnormalities compared with unaffected women. This has to be properly told to her because, otherwise they will not be able to understand suddenly if they get an anomalous baby. Seizures should be controlled preconceptionally, preferably with monotherapy. Usually they are on multi-drug therapy. It has to be brought down to monotherapy. And I will tell you which are the drugs to be avoided also. Valproic acid should be avoided as it has increased teratogenic effect. Also, we have to give supplemental folic acid 0.4 milligrams per day, at least 1 month before conception. Well, this is a very tricky situation. We won't know when exactly she's going to become pregnant. You can give 3 months, 6 months, doesn't matter. Folic acid is always good for the body anyway. It's a water soluble, so there is no fear of hypervitaminosis. But once she becomes pregnant, the dose should be increased to 4 milligrams when she becomes pregnant. Now let us look at what is the effect of pregnancy on epilepsy. Does it improve epilepsy or does it worsen epilepsy? Researchers feel that it does not increase in the frequency of seizures just because she became pregnant. So if at all she has seizures, it is like in her usual frequency. Pregnancy does not increase the frequency. Although some studies have shown increased seizure rates with attendant mortality risk and fetal malformation. Let me tell you little later why exactly you feel there may be a increased frequency. That is not exactly because of pregnancy, but during pregnancy certain changes happen. That's why apparently you feel that there is an increase. I'm going to explain that little later. The incidence of seizures have been further controlled with newer refined techniques of prescribing the optimum dosage of anti-epileptic drugs. So that's why it does not increase because of pregnancy. Plus, we have no better way of controlling it. So on the whole, there is no change, I can say. Increased seizure frequency is often, so I was just promising in the previous slide that I'm going to explain to you why some cases there may be apparent increase of the frequency. It may be because of subtherapeutic anticonvulsant serum levels. You know what happens during pregnancy? The metabolism, the absorption, the excretion, all these things are, changed. So because of which it may happen that there could be subtherapeutic anticonvulsant serum levels and a lower seizure threshold generally during pregnancy. That's why there could be a problem, or it could be a combination of both. The subtherapeutic levels may result from pregnancy-induced nausea, vomiting, decreased GI motility. I was just explaining to you the different changes that diminish drug absorption and hypervolemia. So that is the reason why there could be subtherapeutic serum levels. Hepatic and placental enzymes also metabolize the drugs. So the drugs are cleared, the water. So maybe you have to increase the dosage of the anti-epileptics during pregnancy. That's what the ultimate meaning of this particular slide. Increased glomerular filtration that hastens the drug clearance. So absorption is less, metabolization is more, clearance is also more. Net result, subtherapeutic anticonvulsant serum levels and an apparent increase in the seizures. Following increase are seen due to epilepsy. Let us see what is the effect of epilepsy on pregnancy. We just saw the effect of pregnancy on epilepsy, the summary is that there is no actual increase in the seizures because of pregnancy, but there could be an apparent increase because of the subtherapeutic levels. Let us now look at what is the effect of epilepsy on pregnancy. The following increase are seen due to epilepsy. Number one is twofold increase in cesarean delivery rates. This is not because of seizure disorder itself. It is because of doctors are scared, patients are scared to have a normal delivery. They think that the normal delivery may trigger a epileptic episode, or during normal delivery, if she goes into epilepsy, what can happen? So they don't want to take a risk, because when you do cesarean section, we are doing it in a controlled environment in the presence of anesthetists. Should there be any requirement, they will also help us. Anyway, most of us prefer general anesthesia for the cesarean in epilepsy patients. Otherwise, normally it is spinal anesthesia. 1.5-fold increase in the preeclampsia and PPH. That's what I told you right in the beginning of my talk. Whenever there is a convulsion during pregnancy, the first thing we suspect is preeclampsia. But here, this particular sentence means something different. A person who has got epilepsy disorder before becoming pregnancy has a 1.5-fold increase in preeclampsia and PPH, maybe because of the decreased threshold, as I was telling in the previous slide. Incidence of non-proteinuric hypertension, labor induction, and postpartum depression also are increased. Hereditary effect. An epileptic mother has 1:30 chances of producing an offspring with a seizure disorder, although the exact mode of inheritance is not known. Right from the beginning, we have been telling that epilepsy is a hereditary disorder. So there's a 1:30 chance of mother having an offspring with the same disorder. Malformation. Currently, this is the major hazard that a pregnant epileptic mother faces. Now, it is both because of epilepsy itself, as I told you, the structural abnormalities are increased because of epilepsy disorders, plus the drugs that we use also can affect the baby's organogenesis. There is what is called fetal hydantoin syndrome. In 1976 itself, Hansen described it, and it comprises of microcephaly, mild to moderate mental retardation, which is really bad, and developmental delays, prenatal and postnatal growth retardation, both FGR as well as post-delivery retardation, facial clefts and dysmorphisms, finger-like thumb, and distal phalangeal and nail hypoplasia. Now, this is not because of seizure disorder itself, but because of the phenytoin sodium that we use for control of seizures, that is causing this problem, and it's called by fetal hydantoin syndrome. Other effects of phenytoin are an increased incidence of congenital heart defects, other than what is listed in the previous slide. Wilms tumor, vitamin D deficiency, hypocalcemia, tetany, and neonatal coagulopathy due to vitamin K deficiency. Incidence of such anomalies is as high as 7 to 11%. So, which is very, very high compared to a general population. In general population, the anomalies are less than 1% sometimes. So, effect of epilepsy on pregnancy, it is believed that many anomalies are related to mere existence of epilepsy itself. That's number one. This is because these women have high risk for seizures, which may cause injuries, abruption, periods of fetal hypoxia, FGR, and IUFT. Infants exposed to barbiturates are often drowsy and may suffer barbiturate withdrawal in the first week. It's almost like a drug withdrawal for the baby. Now, what is the treatment of epilepsy? In pregnancy, the physiological increase in blood volume, as I already told you, hypervolemia, nausea, vomiting, decreased gastric motility, and non-compliance are important causes of decline in circulating drug levels. So we have to keep this in mind. Plus, there is increased clearance in the kidney, from the kidneys, and metabolism also is increased. This could aggravate the frequency of seizures, so careful drug level monitoring is desirable. Further, phenytoin and barbiturates are known to accelerate hydroxylation reactions in the liver by inducing microsomal enzymes. So as folic acid is the coenzyme in these reactions, there occurs a rapid turnover of folate, which could lead to its deficiency. Now everything makes sense. That is the reason why we give folic acid prophylaxis before they become pregnant, and we step up to 4 milligrams once they become pregnant, because folic acid turnover is very, very high because of the phenytoin and barbiturate, which accelerate the hydroxylation reactions in the liver. So hence folate supplementation becomes necessity. Now this is the new drug, levetiracetam, newer anticonvulsant. Exact mechanism of action is not known, but it probably works by slowing abnormal nerve impulses in brain, does not pose a major risk to the neurological development of the fetus. So it's very safe, unlike other drugs that are used. It is given in 500 milligrams twice a day orally. Additional dosing increments may be given up to 1000 milligrams per day, additional every 2 weeks, to a maximum recommended daily dose of 3000 milligrams. I have never seen anybody receive that much of dose. So preconceptional counseling, I have already told you, prolonged seizure-free period should be necessary for, and then you can taper off and discontinue epileptics prior to pregnancy. If she has been having a prolonged seizure-free period, let's say 10 years or 15 years of no seizure, you can actually taper off the drugs before pregnancy. Grand mal epilepsy should be treated first with phenobarbital, and if patients have complex partial seizures, primidone or carbamazepine is worthy a first try. But during pregnancy, seizures controlled and she is pregnant, then no attempt is made to change her medications or dosage. The same medication should be preferably used with the same dosage. If possible, change over to monodrug therapy. Trimethadione and valproate are not advisable during pregnancy, so you may change over to the other drugs. Folate supplementation, as I told you earlier, should be given during pregnancy. Encourage to take medication regularly, and we have to tell her that during pregnancy, the drug levels may come down actually for the reasons which I have already explained. Not to deprive herself of sleep. This can really cause problems to her. Should she experience excessive vomiting, she is advised antiemetics so as to ensure drug absorption. Anticonvulsant drugs levels should be frequently monitored and dosage is adjusted. Ultrasound and fetal echo, because we have seen that fetal anomalies are increased by 7 to 11%. So at 18 weeks to detect anomalies and at 4 to 6 weeks intervals thereafter to detect FGR. Vitamin K, we have seen that it decreases, so 10 milligrams per day from 34 weeks for patients taking phenobarbital, primidone, and phenytoin. Caesarean reserved only for obstetric indication. Just because she is epileptic, you don't have to jump into cesarean section. It is better to control it, and if she is controlled, vaginal delivery can be offered. A neonatologist must attend delivery because baby will have a problem, and there may be structural problems, there may be vitamin K deficiency, there may be withdrawal symptoms for the babies. All these things are better handled by a neonatologist. Babies administered 1 milligram vitamin K IM straight away. In conclusion, epilepsy is not a contraindication to pregnancy, and cooperation between the doctors and patients often ensures a favorable outcome in most cases. If it is status epilepticus, transfer her to intensive care facility, start infusion with normal saline and not 5% dextrose, add vitamin B complex. Blood, of course, is sent for CBC, ABG, drug calcium levels, magnesium levels, RFT, RBS, electrolytes levels. Oxygen is given 8 liters per minute by nasal catheter or face mask. Document electrocardiogram. Administer a bolus of 50 ml of 50% glucose in case she is hypoglycemic. Administer injection thiamine 100 milligrams IM. And infuse diazepam. We have seen even in eclampsia, if there is status epilepticus, after giving magnesium sulfate, diazepam is an excellent drug. Only thing is it has to be given very slowly, IV over a period of 2 minutes. If seizures persist, push additional 10 milligrams, but slowly. If continues further 20 milligrams slowly, do not exceed 40 milligrams. That's the maximum, 10, 10, 20. Initiate IV dilantin. Loading dose is 18 milligrams per kg at 50 milligrams per minute. If hypertension develops, slow down the infusion rate. Levetiracetam, 1000 milligrams IV followed by oral 500 milligrams BD may be also given. Monitor with ECG. Watch out for atrial and ventricular conduction depression, ventricular fibrillation. In case seizure persists, initiate phenobarbital drip because diazepam has not worked there. No faster than 100 milligrams per minute until seizure stop or a maximum dose has been reached. Undertake endotracheal intubation if the patient is unconscious and if she cannot breathe and there is a fear of any aspirations. Monitor vital signs. If seizures persist, institute general anesthesia with halothane and neuromuscular junction blocker. Everything has failed. The phenobarbital drip also has failed. Now the only other option is general anesthesia. If an anesthesiologist is not immediately available, administer 50 to 100 milligrams of lidocaine by IV slowly and follow it up with IV infusion of 50 to 100 milligrams diluted in 250 ml of 5% dextrose in water at 1 to 2 milligrams per minute. We should ourselves be able to take care of the patient until anesthetist arrives. If delivery is imminent, alert the pediatrician. These neonates are prone to develop coagulopathy, hence should be getting 1 milligram of after birth, which I'm repeating for the second time. Postpartum, monitor the drug levels and these change rapidly. Keep that in mind. Thank you very much for the invitation and kind listening to the talk.
Yes, Dr. Pai, can you hear me?
Yes, sir.
It's an excellent talk. You are really a good teacher. I feel like a student again. It's a nice, and really it is when the patient, unconscious patient is coming to our emergency ward, definitely we should always try to go for differential diagnosis, and then seizure problem due to epilepsy is a very important. I always tell my students also. I shouldn't forget about other causes like meningitis or some malarial, encephalitis, malaria in our area, very common. These conditions are to be ruled out. But basically, I think when you get the history, and then you always they should come to the pre-pregnancy counseling, and patients should be nicely counseled against use of drugs, and then folic acid should be supplemented adequately, and they should get pregnancy, and they should be observed very nicely throughout her pregnancy. And I think this kind of patients, if you observe them, you might detect some problems, and definitely you can't help to reduce the 5% congenital malformation rate because of the drug users. In those cases, we should be very carefully go for termination if necessary. But other cases, I think under close supervision, we can give a healthy baby to a healthy mother. Yeah, that's nice. And that new, also you mentioned, I didn't know about the drug. It's a really good drug. And step by step, how to manage the patients is very important for students, I think. Yeah, nice.
Thank you.
Excellent presentation, sir. Dr. Swati, go to your comments, please. Dr. Swati. PK sir, your comment, please. Such an excellent presentation.
I think I was quite happy to see that Dr. Muralidhar Pai has covered epilepsy in thorough detail. We have been listening people talking about gestosis, preeclampsia, and all that again and again. I don't know what we are gaining. But epilepsy, the way he has covered, I think I'm sure we are all confident. We have managed patients in past, but normally we take opinion of physicians. Just to be on safer side, on paper. It's not that we don't know how to manage, but he has given us thorough knowledge of conversion, especially the commonest epilepsy during pregnancy. And I'm thoroughly impressed, Dr. Muralidhar Pai. I'm thoroughly impressed.
Thank you,
and
sir.
I enjoyed listening to you. And I'm sure all those who have joined us in this webinar must have benefited by your talk tremendously because you have covered it almost completely. Thank you, and nice to see Dr. Pranay Phukan after a long time. Hi, Pranay.
We always long to hear Dr. Muralidhar Pai, sir. We wait for his presentations whenever he presents us in the YouTube or wherever we find. I like to hear him. So thank you, sir, for being with us.
Thank you, ma'am. Thank you.
So Sneha, madam, can we go for the fifth or not? Well, na? So I think we will conclude with this, and I take the vote of thanks I'll be giving. So by grace of God and blessings of seniors, we come to the end of very successful webinar, and now I have the pleasure to propose vote of thanks. At the outset, I thank our chief guest, Dr. P.K. Sir, for accepting our invitation and staying with us till the end, and really it inspires us and encourages us to work more. I thank and respect Pardesi Sir and Sujata Dalvi Madam for joining and blessing us on such a short notice. I thank our revered guests of honor, Dr. Krishnendu Gupta Sir and Dr. Bhaskar, for joining us when they are so busy in the arrangement of AICOG. I thank all the proficient speakers for taking so much pain to prepare their presentations to highlight what is new in the treatment. I thank Dr. J.B. Sarma Sir, Dr. Mangesh Narwadkar Sir, Dr. Saswati Sanyal Chaudhary Madam, and Dr. Muralidhar Pai Sir. I thank all the very skilled chairpersons, Dr. Amal Kumar Phukan, Dr. Kiran Trivedi, Dr. Jasmina Sharma, Dr. Barsha Kadam, Dr. Deepti Goswami, Dr. Swati Gore, Dr. Kishore Ratnurkar, Dr. Nilakshi Phukan, Dr. Pranay Phukan, and Dr. Rakhi Sarda. I thank Dr. Sneha Bhuyar Madam for taking this idea to bring East and West at one platform for sharing knowledge. Thank you, Madam. I thank my co-convener, Dr. Kalpana, on such a short notice. She was with us and did the moderation. I thank our academic partner for SHIELD, especially Dr. Nishant and Sahiti, because since morning I'm troubling her, do this, do that. So thank you so much, dears. So with this, I conclude. Thank you, everybody, and we'll see you again.
Suman, just let me tell you. Hello, Suman.
Yes, sir.
I want to wish Sneha Bhuyar complete and fast recovery from her sore throat, and we would like to hear her sing next time. Thank you very much and good night.